Thank you, Hadarsh. I appreciate it. I figured, it's 4 o'clock. About this time, I'm usually in my pajamas, so I decided to go a little casual. So I hope you certainly can as well. So what we'll do is we'll get started with acid-base disorders in medicine. Okay, so the first question, a hospitalized 62-year-old woman has a 2-day history of small bowel obstruction manifesting with profuse vomiting requiring suction, blood pressure is low, tachycardic, looks dehydrated or volume depleted with skin turgor, diffuse abdominal pain. The BMP has those labs, which you guys can read. You can see what the ABG is. A pH is 7.4, a PCO2 of 40. Which one of the following best applies to this patient? No significant acid-base disorders because the pH and bicarb are normal. The patient does not have a metabolic acidosis because of the normal blood pH. The patient has a metabolic alkalosis, D, metabolic acidosis and respiratory acidosis, or E, the patient has a mixed metabolic acidosis, metabolic alkalosis. Lock in your answers. Okay. Good. E, wonderful. So we're going to go back to that question. But first, we're going to sort of summarize the talk, and that we're going to talk about high yield information. We're going to talk about basic concepts, acid-base nomenclature. I'm going to give you a stepwise approach on how we talk about or think about these problems. And in between, we're going to sprinkle in these questions and go through the answers. Okay. So first, one of the concepts is that carbohydrate and fat metabolism generate about 15,000 millimoles of CO2 a day, and that CO2 is volatile acid. And we call it volatile acid because it combines with water and produces a hydrogen. And that is sort of the definition of a volatile acid. And under normal conditions, your lungs eliminate all that. And therefore, it has CO2 produced has no impact on acid-base balance. So the other part of acid that we get is from our diet and really the metabolic processes of our cells, and that forms non-volatile acid. And usually it's about 50 to 100 milliequivalents a day that the kidney has to get rid of, usually around 50 a piece from the metabolic process and the diet process. And in order to maintain your acid-base balance, the kidney has to do a couple things. It first has to excrete all those non-volatile acids with urinary buffers, and the urinary buffers are typically phosphate. It has to replenish all the bicarb that's been consumed with those non-volatile acids. And then all that bicarb that's in your blood. So if we measure a blood and we say that typical bicarb level is 24 millimoles a day and our typical GFR is 180 liters a day, that's over 4,000 milliequivalents of bicarbonate that needs to be reabsorbed just to start. And this is a pictorial of that. And the green areas is where we generate our acid. And it goes into the extracellular space with a pH of being around 7.4. And the blue areas, the kidneys that are lungs, and that's where we get rid of that acid. So again, the CO2 getting blown off by the lungs, and that CO2 comes from fat and carbohydrates. The kidneys filter a bunch of bicarbonate and have to reabsorb it all before anything even starts. It generates 70 millimoles in this example. That's the addition of the 30 and 40 that's metabolized and consumed from the diet, and we pee out that amount. And that's how we create homeostasis. So there's acute and chronic consequences of acidosis. There's cardiovascular, and there's decreased contractility because you get vasodilatation. There's if you have increase in breathing with hyperventilation, if you have a metabolic acidosis. You can get with elevated CO2 levels, obtundation and coma. For chronic conditions, you can certainly get more kidney stones, specifically uric acid stones and actually calcium oxalate stones. We know in CKD, you actually have CKD progression in metabolic acidosis, and you get renal osteodystrophy because your bones are wonderful buffers, and they buffer your blood. And then specifically in children, you can get musculoskeletal issues in terms of growth retardation, sarcopenia. And I put in the slide deck just for you to have as what your typical values would be for acid-base parameters in determining where you're going to be obtaining the blood from. And it really should be no surprise that your venous blood has a little lower pH, carries a little bit more CO2 as it returns back to the heart and into the lungs. So before we really move forward with more parts of the talk, we really have to talk about some of the pioneers in acid-base physiology. And so let me start with this person who you might know. All right, and I know there's the millennial generation now. Let me just tell you, this is Mrs. Brady from the Brady Bunch. This is more of a contemporary picture of her. And you might know her as Florence Agnes Henderson, who, sadly to say, passed away in 2016. And then what about this guy, right? Michael Knight from KIT. And this is a more contemporary picture of him as well in his Baywatch days. And this is David Michael Hasselhoff. And so really together they've created the Henderson-Hasselhoff equation. And I know you're laughing hysterically right now. I can just sense it. So I just wanted to start with the next question. Should I keep this joke in for the next year's presentation? Please lock in your answers. That's funny. I'll keep you guessing. All right. 2/3. All right, so it stays another year. It survives. So for the real Henderson-Hasselhoff equation, the real point of it is it's really what bicarbonate is and CO2 and how those both impact pH. And so this is the classic equation here. So what you can do when you're on rounds and you're wanting to see if your ABG is correct is you would plug in the numbers here. And this alpha is really a solubility of what PCO2 is at 37 degrees, and that's a factor of 0.03, and you do a log formation. And you can plug in your numbers and come up with a pH of 7.2. But the reality is that's pretty challenging to do when you're on rounds. So what I'll do is something very similar. It's derived from the Henderson-Hasselhoff equation, and it's a little bit easier to do on rounds. So you'd sort of plug in the numbers here, and what you would get is a nano equivalent per liter of hydrogen, and that's pretty impressive, actually. This is a very, very small amount. So I told you we ingest in 50 to 100 milliequivalents per day of hydrogen. The reality is if you were to convert that into nano equivalents, that would be about 100 million. And so you would actually, your body regulates down to 63. So what you would do is you take this number 63 and you would track it over this chart. And you're saying to yourself, oh, 63 would equal a pH of 7.2. And you're probably saying to yourself, oh my God, I'm not going to be able to remember this chart. But it's a little intuitive. And so how you sort of think about it is you take a 7.4 pH and lo and behold, you have a 40 hydrogen concentration. If you reduce it by 10, you bump up a pH of 0.1. If you add 10 hydrogen, you're now down a lower to 7.3. If you add roughly another 10, you're at 7.2. And after 7.2, you jump by 20. So this is what I sort of do and keep in the back of my mind as I'm on rounds.